everybody. It's nice to be here speaking on a new topic for me to present and a new audience here affiliated with Zomedica. So it's exciting to be here. As Emma had mentioned, yep, I'm from Western Maryland. I did my undergrad here in North Carolina, where I am at Chapel Hill. So go Tar Heels if there's any Tar Heel fans out there. Went to Virginia Tech for vet school. Did my internship at the original Florida Vet Specialist, what was the original Blue Pearl before it became Blue Pearl in Tampa, and then did my residency at a private practice in South Florida. Stayed there for about 6 years. Got tired of the heat. Wanted to go someplace with maybe some mountains nearby. So came back to North Carolina. I've been at a private practice here in Charlotte, North Carolina for about 9 years now, which is crazy. It's been that long, where I'm the only ophthalmologist here and part owner of Charlotte Animal Referral and Emergency, a big referral specialty clinic here. So it's great to virtually meet you all. So let's get into it. So the reason why I thought this talk would be important to do at some point is, there's some general practitioners who do enucleations and enjoy it, but feel like they could improve on it. And I think there's also probably a lot of general practitioners who are intimidated by it. And I think the thought is it's just taking an eye out that's already blind. What can it hurt? But it gets a little scarier when you get in the orbit and how to approach it and what do we do. So part of this talk is getting comfortable with this surgery. And it's really learning a lot of tricks of the trade that I think if you learn the proper setup, the proper instrumentation to use, we can really make this a lot easier. So, and I think by doing that, you have less complications. You can shorten your surgery time that, ideally, maybe you can be in and out of there in 20, 25 minutes versus I hear a lot of people tell me that, they struggle, they're in there for an hour, maybe longer. And so my hope is to get you guys a lot more comfortable with less issues post-op. So, as far as why we do enucleation, that's probably obvious to a lot of you guys, but what I see the most cases for are things that cause intractable pain. So a ruptured cornea, glaucoma that is unfortunately too far progressed and the patient is now blind, and now it becomes more of just a pain procedure to get them comfortable and a good quality of life. If there's some sort of cancer that's either in the eye, around the eye, or in the orbit, an infection that's also in the eye or around the orbit as well, or some sort of traumatic issue like an ocular proptosis, as is the case in this picture, which we've been seeing a large amount of. I've gone this long, almost 20 years, but in my career with residency and out in practice, and we haven't seen a ton of proptosis. In the last 3 months, we've seen a ton of them. So I don't know what's happening out there. All the dogs are not enjoying their housemates very much. But so before we get into the enucleation, I just figured we'd touch base really quick with you guys about what other options are out there that owners can consider, so that you guys can maybe discuss that with them as well before we jump to just taking the eye out. The other permanent options that exist, one is a ciliary ablation, or a CBA, where what we're doing is injecting gentamicin into the back of the eye, into the vitreal cavity. That's essentially close to those ciliary bodies that produce aqueous humor. So we're trying to kill those ciliary bodies. And gentamicin does that really well. About 20 to 30 milligrams is what we inject. Some people inject cidofovir, the antiviral, and have had some success with that, but the majority of ophthalmologists still use gentamicin. The main indication is for glaucoma. So those other things that we talked about that we would pursue enucleation, like a ruptured cornea, obviously that's not going to work. This is just for glaucoma, whether it's primary, secondary glaucoma. The benefits, it's pretty successful. We have about an 85 to 90% success rate that one injection is going to control that pressure and make these guys comfortable long-term. It's also minimally invasive. It's less cost because we're only doing a mild sedation. So maybe we're doing a twilight sedative, or if we have a lot of other health issues, maybe we're given a little butorphanol and a little midazolam just to kind of take the edge off to do it. So that's the benefit. It's cheaper, less invasive to do. The risks are that there's about 10 to 15% that we do this injection and it just doesn't work long term. So we either need to repeat it or consider other options. I do warn people that cosmetically, the eye is going to change. We're going to get some blood inside the eye. We're inevitably going to get a cataract inside the eye. And probably about 10 or 15% of these cases, the eye will slowly shrink down and become thecal over time, which again, doesn't matter to the patient for comfort, but it's a cosmetic change that the owners want to be aware of as well. The only other risk that I'll mention is there's a recent study out in the last couple of years showing that if the glaucoma is secondary in nature to, let's say, a cancerous process in the eye, and maybe this is normally a benign process, something like an adenoma, or even many of the melanomas that we see in dogs are unlikely to metastasize or spread, and we do a ciliary ablation injection, there is some evidence to show that we may have a risk of converting that mass to a malignant transformation through the injection and the inflammation that it causes afterwards. So if there's any risk that a tumor is what's causing this, we usually won't do the CBA with that eye. The other option that we would have is also a permanent issue, mainly just for glaucoma, primary, secondary, but it's more of a cosmetic procedure where essentially what we're going to do is take all the innards out of the eye, if you will. So we're keeping the cornea, we're keeping the sclera, we're making an incision into the eye, and we're removing the lens, the iris, the retina, the ciliary body, the vitreous. So we're removing all that out of there, and we're actually placing one of these prosthetics, which is kind of just like a rubber super ball. That's really what they look like and how they bounce as well. But we place that within the sclera and within the cornea, and then we suture that. So then they still move the eye, they still blink the eye, just like this picture at the bottom. They tend to be a little cloudy. They always look kind of bluish cloudy because of the scar tissue that's there. But most people are pretty happy with that, with still having the appearance of an eye that can move and blink. The benefits, it's going to resolve the glaucoma. We know that for sure, but we get the cosmetic appearance of the eye. The risks, if we think we have a cancer or an infection inside the eye, this is not the ideal option to choose. It is a longer recovery afterwards. So they have to have a cone on longer, though a little more painful for the first probably week after surgery than an enucleation. And I do caution people if they get some sort of corneal disease, we still have to treat that because the inside's fake, but the outside's not. So dry eye, an ulcer, something like that, we still want to treat those things just like we would with a normal eye. So now getting back to talking about an enucleation. So before we talk about the fun stuff of what we're going to do and how we do this surgery, we'll talk a little bit more just about anatomy, just to get the boring stuff out of the way. Just to kind of orient yourself when we talk about the eye, the bone and bone structures around the eye, we're looking mainly at the frontal bone. We're also looking, and the little notch at the top is that little zygomatic process of the frontal bone. At the front of the eye is going to be the maxillary bone. Tucked right down inside there's the lacrimal bone. That's where that nasolacrimal duct would run down from the eye down to into the nose to the nares. Then we have the zygomatic arch that's lateral to the eye. We also have that vertical ramus of the mandible that'll make up kind of part of the orbit as well. Then we have a couple bones that are medially on the ventral portion, which is the palatine bone and the sphenoid bone. And the sphenoid bone's where those foramina are located, where a lot of the muscles, vessels, and nerves are going to run through. The one thing to note when we look at the orbit of dogs and cats, so people, we have a complete circular bone that encases our eye. It makes it less prone to certain types of injuries, less likely to get a proptosis injury like we see in these dogs that have, like I said, been coming in the last couple of months. Whereas dogs and cats, they have this lateral canthal ligament. So it's not a complete orbit, and it's basically this ligament that closes the outside portion of it. The other thing that I just want to note is that the orbital floor is essentially just soft tissue there. The reason why that's important is sometimes, I'm sure as you guys do a lot of dentals and dental procedures, those the roots of those teeth can run close to that orbit. And there's also some risk when you go up there that the infection can come close to the eye, so we can run into some orbital abscesses. And then also, as you're doing a procedure to try to maybe remove an infected tooth, that's some thin tissue that separates the eye from the oral cavity. So if we go too far back there, there is a chance that we could go through that soft tissue and accidentally penetrate the globe. Happens occasionally in dogs, and a little bit more frequently in cats that we'll see it in. So just some landmarks to be familiar with. And speaking of those foramina, the most important ones that we're going to relate to the surgery today, one is the optic foramen. What passes through there is the optic nerve and the internal ophthalmic artery. And then we have our orbital fissure, where cranial nerves 3, 4, 5, at least the ophthalmic branch of 5, that's what innervates the eye itself and sensation to the cornea, and also the orbital vein that would come in through there. And then we have the foramen rotundum as well. And that's where the internal maxillary nerve and artery come in together there. Just to review some of the vessels, because these are the things that are obviously going to give us the bleeding that sometimes we're cursing because we can't get it to stop in there. But the veins that are going to drain the blood. So the main one is going to be the facial vein that you'll see that kind of goes up here and then branches to the ventral part of the orbit, which is the deep facial vein. And then nasally and superiorly, that's the angularis oculi. So we may run into either one of those if we get a little bit too deep in the orbit where we shouldn't be, and that can cause some excessive bleeding if we were to transect either of those. And the main artery going into here is the maxillary artery that's going to penetrate the structures around the globe and then branch off to the globe itself, to the muscles, and then penetrate into the retina, the choroid, the uveal tissue, all those things. So now we got the anatomy lesson out of the way. What surgical techniques already exist? My experience, and you guys, correct me if this is different, but the most common technique that I hear that general practitioners use is a transpalpebral enucleation, where you close those eyelids with sutures, and then essentially we incise around and through those sutured eyelids to get down through the orbit. Where we're just going to kind of remove that altogether and take that eye along with the eyelids all out in one contained region. And the benefits, the biggest thing here is this would be most useful for cancers if they're around the orbit or extending outside the scleral wall of the eye, and we want to try to get all that out together, or an infection that's extended outside the eye or it's within the orbit as well. So removing all that together is going to give us a better chance to get all of that out. The risks, in my mind, I do think it's probably a little bit longer surgery time just because of the way the technique is done. I think it's a little bit longer learning curve to do this procedure and make sure we're approaching it the way that we should. And I've just seen a little bit more bleeding this way because, as you'll see with the other technique we'll talk about, it's a little bit harder to isolate the vessels that we want and maybe be able to identify them and stop the bleeding right away as we transect through them. The other way, and this is what we're going to kind of do today, we're just going to do some tweaks of this, is the subconjunctival enucleation, where with the eyelids open, you're going to incise under the bulbar conjunctiva, where we make an incision through that conjunctival tissue right on the eye, and we transect back, remove that tissue. We go through those extraocular muscles, eventually get back to the optic nerve. So again, that's what we're going to do today with just a couple small tweaks, but I'll try to give you guys some clues on how to do that. To me, the benefits here, it's a quicker procedure. I think you're able to identify the individual muscles, the extraocular muscles, the optic nerve a little easier. So then if we cause a little bit of bleeding, we're able to localize it and stop it quicker. The risks, maybe a little bit less ideal for those things I talked about. If there's a cancerous process throughout the entire orbit or an infection, we got to work a little bit harder to try to get all that out of there with this technique. So what we're going to do again is that subconjunctival enucleation. We're just going to modify the steps of how this normally goes to try to get better exposure. We're going to talk a little bit better about how to set up to make this easier to get better a view into the orbit and into the globe. And then we'll see if that allows us to learn a little bit quicker procedure, get a little bit less bleeding, a little less swelling afterwards as well. One of the big things that I see when people when general practitioners set up for an enucleation is they set them up in sternal recumbency, and that may be true for many of you. I've always found that much harder. So we actually set them up in dorsal, where the nose is pointed straight towards the ceiling, as you can see in this view right here. The eyelids are parallel with the table, and I find that is the easiest way to not only access the globe, but get down into that deep cave that you're going to be working in with that orbit. And so that's a huge thing that I would adjust if you guys are doing it in sternal recumbency. I would switch them to this. I think we're better to be seated because you're working in a much smaller area. I also think that because I'm an ophthalmologist and we're lazy and we just want to sit through surgery. So of course I'm going to be a little bit more in favor of that. But I do think it makes this process easier as you're digging around in the orbit. The positioning of the head, like I said, you want that nose pointed pretty much straight up towards the ceiling. You want that eye, those eyelids, upper and lower lid, kind of parallel with the table. And sometimes to get them in this position, we use a couple of things I'll show you on the next slide, but we will sometimes use a sterilized leash that's here that's only used for this procedure, where we'll tie it on the nose and then tie it to the table just to keep them in position. Bigger dogs with longer noses, they might try to flop over a little bit more. So we'll use the tie for those guys. The best way that I found to get these guys in the right position, if you guys haven't had one of these or don't use one, they are fantastic. We use them for all of our surgeries, including intraocular stuff like cataract surgery and corneal surgery, but we use it for this as well. So we use these vacuum packs that we put their eye in place and then suck that out, all of the air that's in there, to position them where they don't move. The ones that we use are VacFix. They've become a little bit harder to find, a little more expensive now. So we've looked at some other options to have as well, but these work fantastic to hold them in the exact position we want, as you can see this underneath here. And again, we'll maybe tie them with a leash if we need to. Instruments, you guys are going to all have your own instrument packs and the things that you love, but I just want to talk about some extra things that I think you should keep in there that, again, will make this surgery a little bit easier. You probably already have Mayo scissors. I use that to make some of the initial incisions that we're going to make through the thicker tissue. But these on the upper right, these Stevens tenotomy scissors. So what these are going to do, they just narrow right down here as we get closer to the blade. And that, whenever we're performing this, allows you to blunt dissect a little bit more fragile and a little bit more with precision to get those extraocular muscles and then resect each one of those. So I love these. I would definitely get a pair of those to help you with this. The second thing are these Bishop Harmon forceps. I'm sure you guys have your Brown Adsons that you use, which I have a pair of the rat tooths as well. But with some of the smaller dogs, when you're trying to grab that thin conjunctiva, it's just a little much. So I actually have a pair of 0.8 millimeter Bishop Harmon forceps that we use. So those are great as well. And they have a little rat tooth at the end. And then these are huge. I think these would make it much easier for you guys to do the procedure, are going to be these enucleation scissors. And that's exactly what they're called. And you can see that great degree of curvature that they have at the end. That's going to allow you to basically go into that orbit and follow that bone around to get right to that optic nerve and transect that. So that makes this process much easier than trying to use your Mayo scissors back there, because then you're maybe putting a little more tension on the globe. You're pulling it up. And what do we not want to do? We don't want to put too much traction on that optic nerve for risk of damaging the contralateral optic nerve as well. So this allows you not to do that. And to, even when those cats that have those big swollen eyes from glaucoma, you can get back there easier and wrap that around the optic nerve to make the incision and transect that optic nerve. So what structures are going to be some of the landmarks for you guys to watch for? The medial canthus here with that medial canthal ligament. I mentioned that because some things that I'll show you guys in some videos, It's very common. That really adheres to the ligament down to the bone nasally. So it's very easy to leave some of that hair that's in here and not remove it. And that's something that'll cause a fistula down the road if we don't get that all out at the time of surgery. The lateral canthus, I mentioned this because this is where we're going to make our first incision to get better exposure. So we essentially transect right across here to open that up more to get better exposure of the eye. And then the third eyelid. Obviously, you guys are going to remove that for the surgery, but oftentimes when you read in the textbooks how you do this, they tend to remove the eye and then remove the third eyelid afterwards. I'm going to encourage you guys to remove the third eyelid early in the process because you get it out of the way. It just gets much better exposure of the globe so that you can then get down to that conjunctival tissue, look at those extraocular muscles, and just get better exposure as you're working your way down through that. So I'd encourage you to remove that much earlier in the process. How we're going to do this, one of the first incisions once we make on the actual eye is going to be the bulbar conjunctiva that you'll want to start your incision about 5 to 6 millimeters back from the limbus. Why? Because you want something to grab onto. And if you incise right here at the limbus, you're not going to be able to grab anything to manipulate that globe. So you want to go about 5 to 6 millimeters back from that to leave yourself a little rim to turn and manipulate this globe. And you'll see in a little video that I'll show you what I like to do to know that I've resected all the extraocular muscles. You can literally grab that conjunctiva and turn that globe 360 degrees and know that you've freed up all the adhesions and all the muscle attachments that are there. Extraocular muscles. So we're going to have essentially 6 total that you're going to have to transect to get to where we need to go. So we're going to have our superior, our ventral, our medial, and our lateral rectus muscles. But then we also have our 2 oblique muscles. We have our superior oblique and we have our ventral oblique. So essentially you're going to be cutting through all 6 of those. Once you get through all those, you've gotten through that muscle cone, then we're going to expose that optic nerve that's in the back. And that's, again, where we want to be a little cautious with how much traction we're pulling straight up. So we want to make sure that we're kind of using the curvature of the orbit to get back there. So this little blue line kind of shows that curvature that we're trying to do to get back there to the optic nerve. That's where these enucleation scissors are going to come into play, because literally those are going to curve right back here and be able to resect that optic nerve right there, so that we're not pulling too much to damage the contralateral optic nerve, which could be a big deal again in kittens. So when we prep these guys, what are we looking to do to have them comfortable and a good plan of anesthesia? So what we use at our clinic, we do fentanyl and midazolam as a pre-med. Some of you guys, maybe you don't carry fentanyl. Before that, I used to use Buprenex and probably midazolam, those two, which would be totally fine as well. But I like fentanyl partly because a little later in the process, we do a fentanyl CRI to keep them comfortable through this. We just use propofol as our induction agent, and then we keep them on ISO along with that fentanyl CRI for comfort. I do a nerve block with all of these guys as well. As long as I'm not concerned there's an infection or a cancerous process that I'm going to seed that somewhere else in the orbit. If there is, we don't do a block. If there's not, this is just a glaucoma case that's now blind, then we certainly would do a retrobulbar block. And just like you're going to see in both of these pictures, maybe this one over here on the right, we have a curved needle that we're going to try to walk right along that orbital bone to then come back and pop through that muscle cone and inject our block into that area. I use a 1.5 inch 22 gauge spinal needle because that's going to be long enough to get back to where I need to be. And you'll literally, if the biggest thing is we don't want to penetrate the eye itself, partly because if we're going to submit that for biopsy, that's going to affect some of the results. Also, because once you get a deflated globe, if you do, it makes it just a little bit tougher to remove that eye with the same surgery we're talking about. So we really want to stay as far away from the globe as we can. So what I try to do is walk the tip of that needle right off that orbital bone as we go through, so that I'm staying closer to the bone, further away from the globe. And then it'll naturally kind of curve down into that muscle cone. For cats and dogs less than 10 kgs, I do about a 0.5 ml of lidocaine, 0.5 ml of bupivacaine, and 0.1 mils of epinephrine, just to help with some bleeding as well. For dogs that are bigger than 10 kgs, we do basically double that. We do 1 mil of lidocaine, 1 mil of bupivacaine, and 0.2 mils of epinephrine. You can also, if you're uncomfortable with this, that's cool. Some people will do a splash block once the eye's out, just to kind of help the pain after transecting all of those nerves and stuff in surgery as well. Just to give you an idea how I do my retrobulbar blocks. So I'm basically going to palpate that orbit. I got my needle curved there. We're going to keep that right on the bone and kind of walk that back until I can feel it pop down in that muscle cone. I'll aspirate back just to make sure we don't have any blood there, and then we'll go ahead and inject. That syringe has more in it because this dog's actually having both eyes done, so we had a little bit for one eye and one for the other, but that's essentially how we do our retrobulbar block. So let's put this all together now. We'll kind of walk through from beginning to end how this should look. This is just slightly sped up. It's like 1 1/4 speed, just so you don't have to sit through a long procedure. But let's walk through every step so you can kind of see it from beginning to end. First things first, we got them positioned properly where the nose is straight up towards the ceiling. We have them in the VacFix vacuum bag, so they're not going to move or adjust anywhere. And then I'm sitting for surgery because, yeah, I'm a little bit lazy. The next thing we're going to do is we're going to transect that lateral region to get a little bit better exposure. That just shows me the globe a little bit more. The other thing you're going to want to do now is go ahead and remove the eyelets. That's going to give you even better exposure. So a lot of times we do that at the end with this technique. I would encourage you to go ahead and do it now. We're going to get a little bleeding that we have to clean up, but that's going to allow for better exposure of the globe. The only thing about doing it now, you're going to have that little carbuncle of hair right here we have to make sure we remove at the end. So now we've removed those lids. Right now is a good time. I'll make my conjunctival incision, but then we're going to remove the third eyelid after that. So blunt dissection, start with my Mayos, and then I'm going to go ahead and move over to the those Stevens tenotomy scissors once I've kind of incised into here. So bluntly going in, dissecting that, and then doing it. So I'm going to go ahead and remove my third eyelid here, making sure I not only get the leading edge, but I get that gland out of there as well. Because if we leave any of that, we're asking for a cyst in the orbit. So there you go. We got that totally moved out of the way. Again, much better exposure to the globe now. So we're going to keep blunt dissection as we go further back, resect the conjunctiva. We resect all of that connective tissue underneath, and then we're going to get to those extraocular muscles that we'll kind of resect one at a time. So we're working our way through, and you'll see some of the extraocular muscles once we get down a little bit deeper here that we're going to, there's one right there we're going to find. I'm going to go ahead and transect that. Work our way through some more conjunctiva. There's another one right there. We're going to go ahead and transect that. And you can see I'm holding that 5 to 7 millimeters of conj that I can rotate that around. Just so you're not having to move around, you can rotate the globe around. You should get to the point, like I said, that you can rotate this eye completely. And there you go. We're going to go ahead, since we have that, we're going to put our curved enucleation scissors back there. I tend to do it dorsolaterally because I just have a little bit better exposure in that area. Bleeding, that's the issue a lot of people get concerned about. And I know a lot of people, we'll talk a little bit more here in a little bit, but I want to make sure we get all of the conjunctival tissue out of here. So I'll show you guys some pictures, but any conjunctival tissue that has pigment, that's a good sign. We should remove that because we shouldn't really see any pigment in the orbit there. So I'm going to remove all of that conjunctival tissue that's there because conjunctiva, the goblet cells there release mucin, and you have a higher risk of getting a cyst. There's that little carbuncle right there, if you guys can see that. So I want to make sure I remove that and don't leave that in the medial canthal region. There we go. We're still getting some bleeding. That's okay. We're going to get a little bit here. I don't suture these guys. It would be very rare because we can usually get them to stop with just time, pressure, our cautery pen that we're going to use, and then Sometimes we use the cautery unit as well. Once we've done that, this is one that sometimes if you have to place something in the orbit to get the bleeding to stop, we'll talk what those options are going to be. This guy he actually stopped bleeding pretty easily, so we didn't have to place anything in the orbit. So then I'll usually flush the orbit. You can just use saline. I tend to use a little dilute betadine just because that's what I've always done, but you can just use saline as well, obviously. Once I've made that lateral canthal resection, I'll just trim that tissue a little bit so it's a little bit more even. So I'll take a little notch right there, just a little notch right here as well, just to make that a more even incision after we close it. And then I do a 2-layer closure. I'll just do kind of like a subcutaneous, simple continuous closure. I won't make you guys watch the full process. You all are very capable of suturing, but I'll just show you a couple steps here how we do it. Little bleeding, we'll make sure we stop that before we close it. I don't want any major bleeders that'll give us a chance to get a lot more swelling afterwards. So there we go. We finish our first layer. In total time for this surgery, we're usually in and out, I would say in probably 15 minutes, 15 to 20 minutes. So it's a very quick procedure. Then we put an intradermal layer in place here as well. And that's pretty much it. If there is, a little bit of incision, I just want to make sure we close up. I'll put a little tissue glue on. I don't really do any external sutures or anything, but that's pretty much it. That's the whole process there. The other changes that can be done, we can put that same implant that we talked about, the intrascleral prosthesis. You can put that in the orbit as well. What that would look like is that implant is literally just sitting in the orbit. The advantages, it puts pressure on those vessels, so it really gets the bleeding to stop if you're still having some bleeding issues. So they have some less swelling after surgery, so they look a little bit better when they go home, less bruising, less swelling. And it's arguably, depends on who you talk to, a little bit better cosmetic appearance because you don't have the concave appearance to it. It's almost like when you close your eye and you got a little bump right there. That's kind of what we're seeing. The disadvantages is that there's a very small risk. Most ophthalmologists quote about a 2 to 3% risk of the implant either getting rejected or gets infected, or if it's too small, it could migrate somewhere around the orbit as well. And most people, when they're getting into this surgery with me or with you guys, they're ready to be done, right? Like they just want to remove this eye and move on. So I really discourage the implant unless people feel strongly about it, because I don't want to take that 2 to 3% risk that we're going back to surgery with this dog at a later point to remove this. So unless people really feel strongly, I don't place them. So how are we going to stop the bleeding? I tend to just keep a cautery pen in there. And for the little bleeders that are around the orbital walls, that works really great. We also have our cautery unit that, if I need that as well for a little bit more stubborn bleeders, we can use. The other things are our hemostatic agents, and this is one of the new products from Zomedica, which is this Betagel. It's an interesting area because the orbit, most of those, if you're having those bleeders, they're going to be really deep in the orbit, and they can be a little tricky to get to with the cautery pen. So that's where something like this would come into play. What this is, so the Betagel is basically a plant-based product that it conforms to that bleeding site. And those cross links essentially form this mechanical barrier to the bleeding to keep it from continuing to bleed. The increased viscosity and the cohesive strength are what really lay on that area and stop further bleeding versus some of the other things that we use, whether it's the little sponges, the hemostatic sponges, they're not going to conform there to be able to do that as well. And this doesn't disturb the fibrin patch that develops over time, so it's still able to naturally clot with time as well. And this product will dissolve basically within a couple weeks. So just to give you an idea how that would look, here's a patient that had a little bit of bleeding deep in the orbit. So each one of these are packaged sterilely separate. So we get that and the little cannula that comes with it. And then we go deep in the orbit to fill that, just enough of whatever you need. So I didn't need a ton. I needed just enough to stop those bleeders in the back, and that's all we really needed. So once we did that, we'll let that just sit and kind of harden over time in there, and then we're essentially done. We can also use some of the other things, some of the absorbable sponges, those gelatin sponges that are out there. They can work okay. It's just if you're having those really deep bleeders and you don't feel like you've gotten enough, then it might be a little bit harder to get those deep in the orbit. And here's a case where I'm just using the cautery pen for some of the bleeders that are right around the skin. And then once we get that, then I would just put one of those little sponges kind of deep in the orbit for helping some of those bleeders that are still there. So once we have that all done, what are the biggest issues that I've seen that I've gotten maybe referred to me because they've had some issues, and what are we going to do about it? One of the things is an orbital cyst, like the picture down here in the lower left. The biggest things that will cause a cyst is if we have conjunctival tissue that's left in the orbit. Because again, conjunctiva produces fluid. We have goblet cells that are in the conjunctiva that produce mucin, and over time, all that mucin is going to build up to cause a cyst in the orbit and cause swelling. So the other thing is if we don't remove the entire third eyelid with the gland. Those are the two issues we'll see that are most likely to cause a cyst. So in these two videos, to give you a guide, essentially I try to remove anything that looks like loose conjunctiva, and a good guide in a lot of these dogs is if it's pigmented. If you're seeing pigmented tissue like this first video on the left, we want to make sure we remove all of that. So in the second video, that's what we're going to do. I'm going to take that pigmented conjunctiva and any of the conjunctiva that seems to be attached to it and go ahead and resect that. There's another portion of pigment you can see right there that we're going to go ahead and take that out. And there we go. We're gonna get a little more bleeding from that, but then we'll use our agents as need be and cautery pens as needed. Other things that I'll see, draining tracts. So you get these out of surgery, they're doing great for a couple months, maybe even a year, and they start having this little opening that's this fluid and maybe even purulent discharge that's formed from a little draining tract in the orbit. My advice to you, if you're seeing that, a lot of people will take a culture, they'll treat with antibiotics. I think you're really just putting a Band-Aid on that. That is rarely the cause so far after surgery. If you're seeing that so far after surgery, I think you're just going to spin your wheels a lot and we're not going to resolve the issue. There's likely something in that orbit that needs to be addressed. So I've had owners come sometimes that are frustrated because we've had a couple of cultures taken. We've treated with a couple rounds of antibiotics. It gets better, then worse again, then better, then worse again, until finally we just have to go back in and explore and find what's going on. One of the issues that will cause these draining tracts, going back to that little haired area, that little hairy carbuncle that's in that medial canthal region right there. That is left frequently. And so I have to go back and make sure we resected that out completely. Other things that'll cause it, some type of foreign material. So maybe an implant that was done that was too small and it's migrated, non-absorbable suture that can be left in there. This was a case that a client had surgery done with a family vet that was out in California about 2 years ago. And for the last year, this is what it's looked like. They've just had this persistent draining tract, and that's how it occurred. They would culture it. They would treat with antibiotics based on that culture. It would get better, then worse, better, than worse. So we finally went in there. it was interesting. So I don't even know what all was in there. There was non-absorbable suture around some sort of implant that they had put in. It wasn't a ball implant, some sort of mesh work that I think they had put in. So I don't know exactly what it was, but we went in, we removed that, we flushed it out, and that dog did great afterwards. Other issues, severe orbital swelling. That's usually because of bleeding, right? And I've had these cases too where they look great in surgery, and then my techs call me and say, "Oh my gosh, it looks like a a baseball that's in his orbit." And for the most part, as we say, all bleeding will stop eventually, and it usually does. We'll put some cold compress on. If they're really active back there, we'll sedate them and keep them chill. And then over the next 24 to 48 hours, most of that comes down. So most of the time, it's going to be fine. It's rare that we have to go back in to the orbit and ligate further. I did have a case of that, though. That was a rescue puppy that had an enucleation done, and they had come to us probably about a week to 2 weeks later, where he kept hemorrhaging. He was probably about 5 kgs, and he had a softball size swelling where his hematocrit had dropped from about 33 to 12. Then he had a blood transfusion, dropped down to 12 again. And so there was concerns, do we go back in and try to find this? Do we keep compression? Eventually we had to go back in. And I think what happened is that they had gone really deep and transected through that deep facial vein that we talked about. And it just kept on bleeding and kept bleeding. So I ended up having to put some hemo clips on that once we were able to find it, locate it, get all the blood out of the way. And then he did great after that. So that's just a case where we probably went a little too deep in the orbit. We hit one of those major vessels down there, kept seeing a lot of bleeding. But for the most part, some swelling, some bleeding from that side of the nose afterwards is going to be normal, and it's going to go away in 48 hours or so. The other thing, which I know kind of sounds crazy, but it happens, and I've seen it as well, is that these little kittens that either were born with a very small globe, or most frequently what happens is they had a herpes infection as a kitten that damaged the eye so bad it ruptured. So then you end up with a very tiny, either a thesical eye or a micro-ophthalmic eye that now has all these adhesions, just like this, because it's symblepharon. That's what herpes virus will do, is it causes the conjunctiva to stick everywhere. So you got a tiny ruptured globe that's really deep in the orbit. I mean, these things can get really tiny. I'm sure you guys have seen some of them. And then you have tissue adhered all over it. So it's easy to think there isn't a globe there, or to go in and try to remove some of that and miss this really tiny globe that can be really deep in the orbit. So as silly as that sounds, I've seen it. So we just want to make sure that we're removing it. It's very rare to have what's called anophthalmos, where we never were born with a globe. So that's literally almost impossible. There's usually some sort of small remnant in there. So if you aren't finding it, we want to make sure we still do some work to try to get it out of there, because it's probably in the orbit.